Sorry, everyone, for that. Anyway, it's nice to be here, and I appreciate this opportunity. So here's what we're going to do today, and it's really about asking a question to the audience. I mean, presenting some information, but presenting a question to the audience that I think our whole society needs to address and think about. And really the question is this. We have a certain conception around mental disorders, and that has been with us now for more than 40 years. And that has been a disease model that really has made drugs at the sort of the first line form of therapy or of treatment. And so the question I'm going to be asking you here today is this. Do we keep on doing what we've been doing? In other words, we have 45 years of doing this certain conception and a certain way of treating mental disorders, or do we do something radically different? And I think you can see why this is an important topic, because when you look at a society and sort of judge a society, one of the ways to judge it is how well does it help people in distress? How does it nurture people in distress and help them back to health? And really, it's in some ways it's a question about, are we a nurturing society? Are we a society that helps people who are in difficulties? Or do we really have a society that in some ways puts other interests ahead of the interests of the people who are struggling? So I still have a little problem with what I'm seeing here. All right, anyway.
What are you seeing, Robert? We see the slide, the question we need to address.
Yeah, I'm seeing, other things over my slide is what the problem is.
You can probably close them out. What are those things that you're seeing?
Well, like your names, menu bar on the top instead of the bottom. Oh, I just moved it there. That's good. Okay, now I'm getting it better. Okay.
You could hide that menu bar by going to the right. There's three dots on the right-hand side, and you click the three dots and it will say hide menu bar. And then if you wanted to get the menu bar back, you just hit escape.
Okay. All right. For some reason, that's not coming up. I'm sorry about this. For some reason, it's a little different.
No worries. I don't know if you want to hit view on the upper right-hand corner. There's a view button in Zoom, and you can hit full screen. That might help.
See, that's what I'm not seeing right now. I don't know what, usually I see this. Hold on. No, that's okay.
Okay.
Let me just get going. I'm sorry about this, folks.
No worries.
How's that? Is that still showing up okay? Not so much.
Not as good. Yeah, not really as good.
Let's go back to full screen. Okay, here we go. All right. So thinking about where the conceptions we have today, where did they come from? We have a disease model of care, and it really originates in 1980 when the American Psychiatric Association published the third edition of the Diagnostic and Statistical Manual. And you'll see here a quote from Jeffrey Lieberman, who's the former president of the American Psychiatric Association. He says, DSM-III was the book that changed everything. And I agree with him, because it became a new way, it provided a new way for us to think about ourselves. In fact, Jeffrey Lieberman at one point said, this is the most important book published in the last 50 years. And I actually agree with him. And he didn't mean just in psychiatry, he meant any book that was published in our literature. Still trying to get something here. Sorry, guys. And I agree with him that because this has changed how we think about ourselves, how we raise our kids. It presented a profoundly different way for us to think about ourselves and how we treat each other's. Well, I'm having trouble today. Okay. So now let's look at where we started with this. Where did this arise, the DSM-III, this disease model? There was two impulses that were present in the 1970s that led to the publication of DSM-III in 1980. The first was indeed an honest scientific impulse. So you had with DSM-I and DSM-II, those were the first two editions of the Diagnostic and Statistical Manual. You had a problem in that the diagnoses were seen as not reliable. In other words, a patient would go to one psychiatrist and get one diagnosis, and then I'd go to a different psychiatrist and get a different diagnosis. And they often also weren't seen as valid. They weren't validated disorders. One disorder wasn't really that different from another. So the scientific thought was, the impulse was, let's do some research and see if we can categorize these different sort of manifestations of psychiatric disturbances into discrete categories: psychosis, affective disorder, depression, et cetera, et cetera. And the idea initially was maybe they would have 15, 18 categories, and they try to do the research and see in what ways they separated out as distinct difficulties. But there was another impulse present with the in the 1970s that really became the guiding thing in terms of what drove the creation of DSM-III. And that was this. During the 1970s, psychiatry as an organization felt it was under attack. It was fighting for its very survival. You had the anti-psychiatry movement that arose in the 1960s, really within academia, which said that psychiatrists don't function as a medical discipline. They're really functioning as an organization or for the purpose of social control. That was what they were really serving as. That was number one. Number two, there was a psychiatric survivor movement that was rising up in the 1970s that said, listen, we want to be free of psychiatric care. We want to be on our own, and we feel that we were harmed within the mental hospitals, not helped. So there was that patient revolt. And then finally, the big drugs of the 1960s and 1970s were the benzodiazepines. Those were the most popular new psychiatric drugs. And they were understood by the late 1970s to be causing addiction. They didn't work very long. People had trouble getting off them. They were even compared in some instances to heroin. So you had all of these things in which that were sort of challenging the place of psychiatry in our society. Oh, and by the way, there was one other thing going on. So before this time, one of the things that psychiatry did was, with the sort of Freudian ideas, was psychotherapy on the couch, psychoanalysis. But in the 1970s, what was happening is psychiatry could improve. Their psychotherapy was any more effective than the counseling or by psychologists or other mental health professionals. So there was also this competition going on for patients in the 1970s as well. So if you go back and look in the archives of the American Psychiatric Association and its discussions at this time, here's what they said. They said, we need to reinvent ourselves. We need to change public's perception of us, and we need to present ourselves as a real medical discipline. And they said, well, what? Because they understood that the doctor in white coats has such scientific prestige in our society. So they said, that's what we need to do. We need to present ourselves as doctors in white coats that treat real physical disorders. In other words, they're going to change themselves from the perception of psychiatrists at this time was more about the Freudian doctor who stroked his beard and had a patient on the couch. They're going to change it from that conception. Oh, and the other conception, by the way, was of superintendents at mental hospitals, such as we saw in the book One Flew Over the Cuckoo's Nest in that movie, which also made fun of psychiatrists. So they're going to say, we got to get rid of that image, and we got to newly present ourselves as doctors in white coats, as if we're treating infectious diseases. And of course, if you go back in the history of medicine, one of the great advances was the introduction of antibiotics in the 1940s and early 1950s. And that's just when you get this elevation of doctors to this very prestigious place in our society. And that's what psychiatry wanted to take advantage of. We're going to be doctors in white coats. So what did they say? How do we do this? we need to adopt what they call the medical model, but it's really a disease model. They're going to say, we are a medical specialty that treats diseases of the brain. And you'll see here what the statement is. He says, there is a boundary between the normal and the sick. It is the task of scientific psychiatry as a medical specialty to investigate the causes, diagnosis, and treatment of those mental illnesses. So this is where they're putting the stake in the ground and saying, this is how we're going to present ourselves to society. So remember when I said that the idea with the scientific impulse is maybe they would find 12 to 18 categories of psychiatric difficulties, and they would try to establish, they would do research to see in what ways they might be discrete. Well, by the time with this guild impulse, this commercial impulse in play, the DSM-III had 265 disorders. Now, why did it have so many disorders? Well, basically, they wanted a definition that would allow anybody who came into their office to be diagnosed with a psychiatric disorder. So that's why you have this extraordinary expansion of the number of disorders. And here's the conception. Now, this was written by Nancy Andreasen. She was the long-term editor-in-chief of the American Journal of Psychiatry, and she's presenting this new conception to the public in a book called The Broken Brain, 1984. The major psychiatric illnesses are diseases. They should be considered medical illnesses, just as diabetes, heart disease, and cancer are. The thought is that each different illness has a different specific cause. There are many hints that mental illness is due to chemical imbalances in the brain, and that treatment involves correcting these chemical imbalances. To understand what a big shift this is, if you go back before 1980, the conception was that human beings are responsive to their environment. And in the Freudian idea, so often is the difficulties are in reaction. There are reactions to difficulties in the environment. They might be family, they might be poverty, there might be social conditions, there might be instances of grief, that sort of thing. But so much of, not all, there was still thought that there's a small core of biological disorders, but so much was thought of, we humans are responsive to our environments. And when things are difficult in our environment, that's when we get these eruptions of psychiatric distress. But this is different now. Now this is going to, so that's a vision in which you have people interacting with your environment. Here's a vision where, or a conception, where everything in fact is happening inside the head of the individual. They have an illness. There's something chemically wrong with them. It's no longer an adaptation to the environment. And if this is so, if there's something chemically wrong, you're adopting a model that says this is going to be a chronic illness. It's going to persist in you because they have this chemical abnormality. So this is a huge shift. And the other part of this disease model is they're already hinting that maybe we have drugs that can fix that chemical imbalance, that problem.